Psychology 1. Be familiar with the 2. Introduction. Somatoform disorders are characterized by presence of physical or bodily symptoms without any general medical cause to explain it, i.e. lack of an organic or physical cause. The term somatoform derives from the Greek word soma for body, and therefore is defined by experiences of bodily signs and symptoms. Kaplan and Sadok Synopsis of Psychiatry, 10th edition, 2007. Individuals who suffer from somatoform disorders often complain of having physical discomfort such as body pains, breathing problems or even paralysis of certain body parts. Dissociative disorders, as the name suggests, refer to the dissociation or splitting apart of one's identity. It can be explained as the feeling of strangeness or disconnect from reality. As is the case with somatoform disorders, the cause of dissociative disorders is deep-rooted in highly stressful and traumatic life experiences. It is in response to coping with such events that dissociative disorders may develop. Gershuni and Thayer, 1999. Somatoform disorders and dissociative disorders have much in common. Both disorders produce symptoms common to those of neurological disorders, such as amnesia, paralysis, etc. Further, in both the disorders, the problem is not a neurological disability but disturbance of consciousness. Conversion disorder, a somatoform disorder, and dissociative disorders were collectively known as hysterical neurosis in the Diagnostic and Statistical Manual of Mental Disorders, 3rd edition DSM-3, 1980. However, when it became clear that conversion disorder was a perceived disruption of sensory functions, and dissociative disorders of motor functions, the two were separately accounted for in DSM-IV 2000. 3. Clinical picture. 3.1 Diagnostic criteria. The diagnosis of somatoform disorders and dissociative disorders can be found in the Diagnostic and Statistical Manual of Mental Disorders, 4th edition, text revision DSM-IV-TR, 2000. The foremost and basic identification of somatoform disorders requires the presence of bodily symptoms and discomfort which have no known physical or neurological cause. The manual. Psychology paper number 15, Clinical Psychology. Further differentiates between 7 syndromes of somatoform disorders based on the symptoms commonly exhibited. These are somatization disorder, conversion disorder, hypochondriasis, body dysmorphic disorder, pain disorder, indifferentiated somatoform disorder, and somatoform disorder not otherwise specified. For dissociative disorders, the DSM-IV-TR states that the essential feature of the dissociative disorders is a disruption in the usually integrated functions of consciousness, memory, identity, or perception about the environment. The disturbance may be sudden or gradual, transient or chronic. It characterizes the following disorders as dissociative disorders: dissociative identity disorder, depersonalization disorder, dissociative amnesia, dissociative fugue, and dissociative disorder not otherwise specified. 3.2 Syndromes of somatoform disorders. 3.2.1 Somatization disorder. Somatization disorder was first described by Paul Briquet in 1859 while observing patients who felt that they have been sickly most of their lives, and complained of numerous physical symptoms. It is therefore also known as Briquet syndrome. It is a somatoform disorder characterized by multiple, chronic, and recurrent complaints of bodily symptoms. Individuals with somatization disorder describe their symptoms in a vague, dramatic and exaggerated fashion. Ietzi, Duckworth and Adams, 2001. They complain of problems in multiple organ systems, usually including symptoms such as pain, gastrointestinal distress, and breathing difficulties. Such patients have long and detailed history of their medical illnesses which they have been experiencing since years and which often recur time and again. As a result, they show high levels of anxiety and worry, and consequently have increased reactions to their symptoms. According to the DSM-IV-TR, the diagnostic criteria for somatization disorder requires that there should be a history of many physical complaints beginning before the age of 30 years and occurring over a period of several years. The experience of the symptoms must cause the patient to seek treatment or cause significant impairment in social, occupational, or other important areas of functioning. The symptoms must include pain symptoms in at least 4 different areas of the body: head, abdomen, back, joints, chest, extremities, rectum, during menstruation, during intercourse, or during urination. 2 Gastrointestinal symptoms such as nausea, vomiting, bloating, constipation, or diarrhea, or intolerance to several kinds of foods. 1 Sexual symptoms such as sexual indifference, erectile dysfunction, irregular periods, etc., and 1 Pseudoneurological symptoms such as blindness, double vision, hallucinations, amnesia, impaired balance, deafness, etc. The most common symptoms reported are nausea and vomiting, difficulty swallowing, pain in arms and legs, shortness of breath unrelated to exertion, amnesia and complications of pregnancy and menstruation. 3.2.2 Conversion disorder. In conversion disorder, patients experience the actual loss or impairment of a motor or sensory function without any apparent neuropathological cause. The most common symptoms of conversion disorder experienced by patients are blindness, deafness, paralysis, and anesthesia, loss of sensation. Ietzi, Duckworth, and Adams, 2001. Also common are conversion symptoms. Psychology paper number 15, Clinical Psychology. That mimic physical illness, such as epilepsy or cancer. Bowman and Marquand, 1996. These symptoms, though having no physical cause, actually happen without the patient having any control over them. The most common symptoms of this disorder are paralysis, blindness, and mutism. Historically, conversion disorder was combined with present-day somatization disorder and collectively referred to as hysteria, from the Greek word hystera, meaning uterus. It was incorrectly thought to affect only women and its cause was attributed to wandering uterus. The common cure for hysteria included engaging in sexual intercourse with strong and young men and giving birth to satisfy the melancholic uterine. Hysteria was also extensively studied by neurologist Freud, who based his theory on his patients who were mostly victims of sexual abuse. In his view, conversion disorder, before it was medically termed, was caused due to psychological conflicts, usually sexual in nature. Even though today the sexual interpretation is rejected, psychologists agree that conversion disorders may be the result of some psychological conflict. B. Erderman, 1995. What particularly sets conversion disorder patients apart from those of neuropathology is that 1/3 of the conversion disorder patients display labile indifference, or beautiful indifference, i.e., they seem completely unperturbed by their symptoms. The DSM-IBTR diagnosis of conversion disorder requires that the symptoms affect a voluntary motor or sensory function, that is, neurological symptoms, and seizure symptoms such as pseudoseizures may also be observed. It also requires that clinicians find a necessary and critical association between the cause of the neurological symptoms and psychological factors. Kaplan and Sadok, Synopsis of Psychiatry, 10th edition, 2007. 3.2.3 Hypochondriasis. Hypochondriasis is characterized by a constant fear or excessive worry about having a serious illness. Hypochondriacs misinterpret their physical bodily sensations as abnormal. They pick up a small bodily dysfunction, such as abdominal pain, and exaggerate its symptom as indicating a more serious disability or disease, such as cancer. Even though they cannot find any medical diagnosis that confirms their beliefs, and even after being reassured of their good health by medical examination, they continue to hold strong convictions of their perceived illness. These irrational fears of being ill, or feeling susceptible to contracting a particular disease, drive such individuals to be avid readers of medical articles in magazines and on the web, visit multiple doctors, try miracle cures, design strenuous health regimes, and have a wide collection of pills. Fallon and Feinstein, 2001. Hypochondriasis was loosely defined until a paper by Gillespie, 1928, stated a strict definition. Based on a review of 13 cases, hypochondriasis, according to him, was characterized by a variety of paresthesias, a thorough observation of bodily function, a firm conviction of illness or sickness, an inability to be reassured, and finally, a failure to respond to psychotherapy. It was not until the mid-1920s that hypochondriasis was listed as a diagnostic category in the American Psychiatric Association APA classification system, NEMIA, 1985. According to the DSM-IBTR, the diagnostic criterion requires that patients be preoccupied with their false beliefs for at least 6 months, despite the lack of medical confirmation. Their beliefs shall not have the intensity of a delusion differentiating it from delusional disorder, or be restricted to distress about appearance differentiating it from body dysmorphic disorder. In addition, the symptoms of hypochondriasis must be sufficiently intense to cause emotional distress and dysfunction of daily life. Kaplan and Sadok, Synopsis of Psychiatry, 10th edition, 2007. Psychology paper number 15, Clinical Psychology. 3.2.4 Body dysmorphic disorder. Body dysmorphic disorder, or dysmorphophobia, originally conceptualized by Morselli in 1886, refers to a subjective feeling of ugliness or physical defect in a person of normal appearance. Andreessen and Bardak, 1977, De Leon, Bott, and Simpson, 1989, Thomas, 1984. It also includes individuals with a minimal physical defect who react out of proportion to this defect. Andreessen and Bardak, 1977, Thomas, 1984. As the name suggests, individuals with this disorder overestimate their perceived physical flaws to the point that they can no longer function normally. They have a distorted perception of their physical appearance. Individuals with body dysmorphic disorder typically focus their attention on the face, ears, nose, hair, breasts, or genitalia. Andreessen and Bardak, 1977, De Leon et al., 1989, Thomas, 1984. Frequent complaints also include skin blemishes and facial wrinkles. Men tend to focus on genitals, height, excessive body hair, body build, and hair thinning, and women tend to focus on breasts, legs, hips, and weight. Perugi, Akiskel, Gianotti, Frere, Di Vaio, and Casano, 1997, Phillips and Diaz, 1997. According to the DSM-IBTR, the diagnostic criterion states that patients have a preoccupation with an imagined defect in appearance or overemphasis of a slight defect which causes significant emotional distress and impairment of normal regular functioning. Kaplan and Sadok, Synopsis of Psychiatry, 10th edition, 2007. In some cases, people with body dysmorphic disorder choose to undergo plastic surgery which usually makes their appearance concerns worse. Beal, 2000. Others may avoid being seen, quit their jobs or become homebound. In extreme cases, the person may also contemplate or even attempt suicide. Phillips, 2001. 3.2.5 Pain disorder. Pain disorder is the somatoform disorder wherein the patient suffers, or focuses on, chronic pain in one area or more without any medical condition or physical cause to explain it. Psychological factors are assumed to play a role in causing and/or maintaining the bodily pain. The patient tends to report the pain in emotional, for example, frightening, terms rather than sensory, for example, burning, terms, and they are ambiguous about localizing the pain or specifying its variation in terms of when it occurs or when it is most intense. Strelzer, Elyashoff, and Klein, 2000. Such individuals also share the fear of pain which leads them to avoid social and physical activities, which further maintain or exacerbate their experience of pain and related behaviors. Asmundsen, Norton, and Norton, 1999. According to the DSM-IBTR, the diagnostic criteria for pain disorder require the presence of clinically significant complaints of pain which have no direct physical or organic cause. The experience of this pain must be significant enough to interfere with social, emotional, occupational, and other functional areas of life. Other than the somatoform syndromes mentioned above, the DSM-IBTR also mentions 2 other syndromes, indifferentiated somatoform disorders and somatoform disorder not otherwise specified. Indifferentiated somatoform disorder is characterized by 1 or more unexplained physical symptoms for at least 6 months which do not meet the criteria for somatization disorder. These symptoms, again, have unexplained etiology. Somatoform disorder not otherwise specified is a residual category for patients who have symptoms suggesting a somatoform disorder, but do not meet the specific diagnostic criteria for other somatoform disorders. Kaplan and Sadok, Synopsis of Psychiatry, 10th edition, 2007. Psychology paper number 15, Clinical Psychology. 3.3. Syndromes of dissociative disorders. 3.3.1. Dissociative identity disorder, DID. This disorder was formerly referred to as multiple personality disorder. Individuals who are diagnosed with DID seem to behave as though they have various personalities with differing identities. These personalities are known as alters. The individual is having the personality before acquiring DID is known as the host. There can be a number of alters ranging from just 2 to about more than 100. Putnam, 1997, Putnam, Garoff, Silberman, et al., 1976. Alters produce mannerisms and behaviors which are usually completely different from that of the host. They may speak different languages, adopt different nationalities, or may even act of a different age. For instance, one of the alters of a 42-year-old woman with DID may act as a girl aged barely 11 years old. The basic function of these alters is to protect the person from extremely painful memories of certain traumatic experiences. Therefore, the number of alters a person has usually depends on the severity, duration, and nature of abuse. Each of the alters has reservoirs of certain memories which define its identity. In this sense, the alters are aware of the host and its experiences, but in very complex patterns, the host is not aware of the alters. Dorahy, 2001. In people with multiple alters, some of the alters may not be aware of the existence of other alters. When the individual encounters a stimulus that triggers a painful memory, an alter takes control of the individual's behavior and the switch remains till another event triggers another alteration. According to the DSM-IBTR, the diagnostic criteria for DID follows that the individual must show the behavior of having two discrete identities or personality states, each with its own relatively enduring pattern of perceiving, relating to and thinking about the environment and self, and ones which the individual has no control over. Additionally, the person must be unable to recall necessary personal information, and this condition must not be on account of any known medical condition in the patient or substance abuse. 3.3.2. Depersonalization disorder. Depersonalization is defined as the sensation of unreality concerning oneself, parts of oneself, or one's environment. Kaplan and Sadok, Synopsis of Psychiatry, 10th edition, 2007. This state of surreal detachment can occur in states of stress, fatigue, or altered consciousness from drug use. Individuals with depersonalization disorder often report feeling as though they have cut off from themselves and are watching themselves from the outside as observers. They feel as though they are in a dreamlike state, disconnected from reality. Derealization often accompanies depersonalization. In derealization, the individual feels the same kind of strangeness towards the world and feels as if other people are also dead, robotic, or unreal. Individuals often experience déjà vu, the sense of having seen or been in the particular place before knowing that this is not really the case, or déjà vu, the sense of feeling like one has never encountered the familiar place before. Depersonalization disorder differs from the other dissociative disorders in that the individual is aware that his/her perception of strangeness is invalid and incorrect. However, the individual continues to harbor such feelings and may also experience the fear of going crazy with such frightening perceptions. Depersonalization, as a dissociative disorder, has also been associated with childhood trauma, specifically emotional abuse. Simeon, Uralnik, Schmeidler, et al., 2001. Psychology paper number 15, Clinical Psychology. According to the DSM-IBTR, the individual must experience depersonalization such that reality testing still remains stable, while causing clinically significant distress and dysfunction in areas of social, occupational, and other important functions of life. The feeling of depersonalization must also not occur coincidentally with another general medical condition, another dissociative disorder, or any other mental disorder, and drug use causing similar physiological effects. 3.3.3. Dissociative amnesia. Amnesia refers to the partial or total loss of memories of past experiences. It usually has a neurological and physical cause, such as a hit on the skull due to some accident. However, when it occurs due to no known organic or neurological cause and seems to have psychological causes, it is identified as dissociative amnesia. Dissociative amnesia differs from organic amnesia in the nature and content of forgetting. Sakim and Devenant, 1991, Civic and Lin, 1995, Killstrom, 2001. Dissociative amnesiacs always show patterns of anterograde memory loss as opposed to retrograde patterns observed in organic amnesia. Further, there is selective forgetting of information, i.e. those relating to the traumatic or stressful event, in dissociative amnesia, and the individuals suffering from such a pattern of memory loss display label indifference to their condition. There are 5 specific patterns of memory loss observed in dissociative amnesia. The most commonly seen is localized amnesia, wherein the memory is blanked out for a certain period of time in which a traumatic event took place. For instance, a survivor of a tsunami devastation might entirely forget the event as it took place, and a few days after that, while the officials cleared corpses and other destruction. It is usually the memory of several hours to a couple of days that is blanked out. Selective amnesia, as the name suggests, is noted when individuals forget specific events that occurred in a given period of time. For instance, in the above example, the man may forget watching the corpse of his family being cleared away but may remember the tsunami as it struck. A third and rare type is generalized amnesia, in which the person forgets his/her entire past life. Another very rare pattern is the continuous amnesia, in which the person does not remember anything that happened after a certain event took place that triggered the amnesia up until the present. In systematized amnesia, the person forgets specific categories of information with the rest of the memory remaining intact. For instance, the person may forget a specific location even he has been there frequently. In general, it has been found that dissociative amnesia affects episodic memory, with procedural and semantic memory intact. Kopelman, Christensen, Puffett, et al., 1994. According to the DSM-IBTR, the defining characteristics of dissociative amnesia are that the individual experiences one or more episodes of forgetting personal information that is usually traumatic in nature. Further, this does not occur due to any other disorder or known medical condition, and the experience of the symptoms causes a significant amount of distress and dysfunction in regular functioning. 3.3.4. Dissociative fugue. Dissociative fugue is an extension of amnesia in that, in addition to forgetting most of the crucial past information, the individual also takes a sudden and unexpected trip and absconds from home. However, fugue patients are more purposeful than the usually confused amnesia patients. They. Psychology paper number 15, Clinical Psychology. also create a new identity for themselves, inventing a detailed past. This identity lasts till the fugue lasts. The length of the fugue does not have any fixed period. Some individuals pursue their fabricated identity for years also. The fugue ends once the individual feels psychologically safe. Reither and Stoudemeyer, 1988, and the person has no recollection of the invented identity and all the events that occurred during the episode of the fugue. Therefore, they display amnesia about the fugue, and the last thing they usually remember is that they left home before the fugue was triggered. According to the DSM-IVTR, dissociative fugue is identified if the individual has a sudden onset of fugue and travels unexpectedly away from home to unusual places. The individual displays inability to recall the personal identity and formulates a new identity of which he/she has no recollection once the fugue ends. Lastly, the disturbance should not occur due to another dissociative or mental disorder, general medical condition, or substance abuse, and the occurrence of such episodes should be significantly distressing for the individual's social, occupational, and psychological functioning. Dissociative disorder not otherwise specified is a residual category for patients who have symptoms suggesting a dissociative disorder, but do not meet the specific diagnostic criteria for other dissociative disorders. Kaplan and Sadok's Synopsis of Psychiatry, 10th edition, 2007. 4. Epidemiology of somatoform and dissociative disorders. Prevalence. The estimated prevalence of somatization ranges from relatively uncommon Fabrega, Mezich, Jacob, and Ulrich, 1988, to very common Barsky and Klerman, 1983, Kellner, 1985. It has been estimated that 20 to 84% of patients seen by primary care physicians suffer from idiopathic somatic complaints. Barsky and Klerman, 1983, Kellner, 1985. The reported prevalence of conversion disorder fluctuates from rare Lewis, 1974, Slater, 1965, Whitlock, 1967, to ubiquitous Engel, 1970. Empirical investigation suggests that 5 to 14% of the general medical consultations are likely to be a case of conversion disorder. Folks, Ford, and Regan, 1984, McKegney, 1967, Stefansson, Messina, and Meyerowitz, 1976, Ziegler, Imboden, and Meyer, 1960. Hypochondriasis, it has been noted, occurs in 3 to 14% of patients seen in medical settings. Kenyon, 1976. Pain disorder is very common in the general population, and some estimate its lifetime prevalence to approximately 5% and 12%. The prevalence of dissociative disorders is a controversial topic as its diagnosis is still debated. Some estimate it to be less than 1%. Rifkin, Giesalbert, Demetu, et al., 1998. For dissociative amnesia, approximately 6% of the general population has been diagnosed. Gender. DSM-IV-APA, 1994, states that the prevalence of somatization disorder is 0.2 to 2% among women and less than 0.2% in men. For conversion disorder, conversion symptoms occur more frequently in women and the ratio is at least 2:1 for women to men. Folks et al., 1984, Gatfield and Goose, 1962, Goose and Perley, 1963, Perley and Goose, 1962, Pertle et al., 1951, Raskin, Talbot, and Meyerson, 1966, Whitlock, 1967. The DSM-IV-APA, 1994, reports a 2:1 to 10:1 ratio in favor of women for conversion disorder. Hypochondriasis occurs equally among men and women. APA, 1994, Gouray, Houston, and Simon, 1997. The estimated prevalence rate for body dysmorphic disorder have varied from rare to 2% in clinical samples. Andreessen and Bardak, 1977, Thomas, 1984. The gender ratio for pain disorder is essentially unknown or unestablished. DID has been found to occur 5 to 9 times more frequently in women than in men. Putnam and Lowenstein, 2000. Even depersonalization disorder is likely to be seen more often in women. Psychology paper number 15, Clinical Psychology. The Nin-Ment Simeon, Gross, Uralnik, et al., 1997. However, dissociative FIG has been observed more commonly in men than in women. Coons, 1999. Age. The age of onset of somatization disorder is usually in early childhood and adolescence. Campo and Fritsch, 1994, Geralda, 1996, Kriechman, 1987, Livingston and Martincanici, 1985, Terra and Gaselli, 1997. The prevalence of conversion disorder in children and adolescents has been estimated at approximately 5%. Maloney, 1980, Siegel and Barthel, 1986. The overall peak age of incidence for hypochondriasis was 30 to 39 years of age. Kenyon, 1964. For body dysmorphic disorder, data suggests that the common age range for it is 15 to 30 years, whereas pain disorder can begin at any age. Dissociative amnesia has been generally found to be reported in late adolescence and early adulthood. Cultural and geographical factors. Conversion reactions are observed more frequently in individuals who reside in rural areas and in less psychologically sophisticated populations. Folks et al., 1984. Some studies indicate that hypochondriasis is more likely to occur in blacks than in whites, however the diagnosis remains fairly unaffected by cultural factors. Dissociative disorders may not be recognized as formal mental disorders. In some cultures, they are seen as a tenable and championed state of trance. For instance, in the Hindu culture as religious practice, meditative trances are triggered to attain a permanent hypomanic state. Castillo, 1997. Socioeconomic status. Somatization disorder is reportedly more common in individuals from lower socioeconomic status, lower educational level, and rural background. Barsky and Klerman, 1983, Escobar, Rubio Stepek, Canino, and Carno, 1989, Swartz and colleagues, 1986. Body dysmorphic patients typically come from middle-class environments. Andreessen and Bardak, 1977. Conversion disorder is more prevalent among low socioeconomic groups. Hypochondriacal complaints reportedly occur in about 3% of medical students, usually in the first 2 years. For body dysmorphic disorders, patients are more likely to be unmarried. Associated pathology. Several studies have noted the coexistence of somatization disorder with other mental disorders. The most prevalent comorbid diagnoses are major depression 54.6%, generalized anxiety disorder 33.6%, phobic disorders 31.1%, panic disorder 26.0%, and alcohol abuse dependence 21.0%. Brown, Golding, and Smith, 1990. Conversion disorder and dissociative disorders are commonly associated with major depressive disorder, anxiety disorders, and schizophrenia. For body dysmorphic disorder, a study found that more than 90% of patients had experienced a major depressive episode, and about 70% had experienced an anxiety disorder, while about 30% had experienced a psychotic disorder. Pain disorder is associated with affective and anxiety disorders, and many pain disorder patients also become depressive and alcohol-dependent patients. 5. Etiology. Somatoform and dissociative disorders have no identifiable biological cause. The etiological factors for them are speculated to be psychological in nature. The basic assumption for dissociative disorders has been that it is a way for individuals to escape traumatic memories. For both disorder, the psychodynamic, behavioral, and sociocultural perspectives have been widely influential in explaining their why and how. Psychology paper number 15, Clinical Psychology. Historically, the psychodynamic perspective, dominated by Freud's theory, has contributed the most to our understanding of the disorders, specifically conversion disorders and hysteria. However, the treatment designed by the cognitive and behavioral perspectives for somatoform and dissociative disorders has been the most effective. 5.1 Psychodynamic perspective. Freud was highly influenced by neurologists Charcot and Joseph Breuer's work in hysteria. Breuer designed what he called a therapeutic technical procedure, wherein he would recreate the particular memories of an incident, which was thought to have caused hysterical symptoms, and bring about emotional catharsis in the patient by inducing them to talk about it. Borrowing from their ideas and works, Freud conceptualized somatic symptoms as a result of repressed childhood memories, perhaps traumatic in nature, and inhibited emotional expression regarding these memories. These memories are pushed deep into the unconscious where the person becomes unaware of them. These traumatic emotional experiences are then transformed into some physical symptom and the person is relieved of his/her anxiety. Freud found that he could induce his patients to talk uninhibitedly about their childhood by bringing the unconscious material to consciousness under a trance-like state called hypnosis. As it turned out, many patients got rid of their physical symptoms with this form of therapy. Although this theory satisfactorily explains conversion symptoms in patients with labile indifference, it still doesn't explain the remaining two-thirds of the patients who still experience anxiety about their symptoms. In this perspective, hypochondriasis, somatization disorder, and body dysmorphic disorder are all seen as defenses against the anxiety produced by unacceptable wishes. Hypochondriasis in particular was thought to be a result of sexual desire. Nemia, 1985. Freud suggested that hypochondriacs were people who, deterred by their superego to direct their sexual energy onto external objects, redirected this energy onto themselves in the form of narcissistic libido. Eventually, this narcissistic libido overflows and finds expression in physical symptoms. Brown and Valent 1981 conceptualized hypochondriasis as repressed hostility. These authors felt that the disorder arose from anger over having been disappointed, hurt, abandoned, or unloved. Rather than openly complain, the individual displaces these thoughts and feelings onto the body. Other analysts thought that hypochondriasis occurred in individuals defending against very low self-esteem and against the experience of the self as worthless, inadequate, and defective. McCraney, 1979. According to this view, it is easier and more tolerable to feel that something is wrong with one's body than with oneself. Similar conflict resolution theories have been posited for somatization disorder and body dysmorphic disorder. Kellner, 1990, Phillips, 1996. Dissociative disorders were recognized in the late 19th century when the French psychologist, Pierre Janet, extensively studied individuals showing symptoms of the same. He coined the term, desegregation, meaning dissociation in English, to explain the phenomenon of one or more divisions of mental faculty splitting off and functioning without the person's awareness. Freud explained dissociation in terms of defense mechanisms. He suggested that dissociative amnesia, for instance, was an extreme case of repression. Similarly, in dissociative fugue, the individual acts out the identity which contains all the desires and drives consciously repressed by the ego. He also claimed that the occurrence of a dissociative disorder is an outlet for the anxiety produced by the interaction of the ego with the ID and the superego. Some studies do support this belief of the psychodynamic view. For example, one study indicates that dissociative patients experience less internal anxiety due to the psychic elements than do alcoholic patients. Alpher, 1996. Psychology paper number 15, Clinical Psychology. 5.2 Behavioral and Sociocultural Perspective. Behavioral theorists believe that mental disorders are a result of faulty learning and conditioning patterns. Sociocultural and behavioral theorists alike suggest that somatoform disorders are inappropriate adoptions of the sick role. Pilowsky, 1994. The adoption of the sick role means that the patient showing somatic symptoms does so by thinking about the gains he or she will acquire because of being sick. A sick person is exempted from responsibilities of home and work and has other people to be sympathetic and attend to his or her needs with special urgency. The person learns to adopt this role if he or she has had a personal experience with physical illness during childhood or recently observed someone with such symptoms, and in both cases, being sick has been rewarding. Such experiences become a positive reinforcement for the behavior to occur again. Ullman and Krasner, 1975. Related to this aspect, in a study by Parker and Lipscomb, 1980, it was found that more hypochondriacal patients claimed that their fathers had been overprotective and their mothers had been more sympathetic towards them when they were ill in their childhood. The sociocultural perspective further suggests that the likelihood of an individual adopting the sick role is also dependent on the culture at large and its general attitude towards unexplained somatic symptoms. Also, if the community frowns upon psychological expressions of emotional problems, then the person of this community is encouraged to somaticize unhappiness rather than psychologize it. Goldberg and Bridges, 1988. Respondent conditioning is another theory used to explain somatoform disorders. It explains that the autonomic nervous system, which controls physiological functions of breathing, heart rate, etc., is subject to conditioning. So, if anxiety is paired, for instance, with minor heartbeat irregularities, then the person learns to associate these insignificant heartbeat irregularities with anxiety, and the anxiety that is triggered further triggers other physiological symptoms. This becomes the basis of hypochondriasis in people. Kellner, 1985. Similarly, for dissociative disorders, the perspective suggests that individuals learn to dissociate as a coping response that offers relief from stress. The social role provided by the particular dissociative disorder operates based on the consequences. Seltzer, 1994. For instance, in amnesia, fugue, and did, the individual gets to escape stress as a consequence by removing painful memories and creating new identities outside conscious awareness. Spanos 1996 further suggests that dissociative identity disorder, DID, is a way for the person to gain sympathy and not be responsible for certain actions their alternate identities perform. According to him, this process occurs due to hypnosis. He therefore called this the hypnotic role that patients adopt, like the sick role played by patients of somatoform disorders. DID is further reinforced when the clinician validates this hypnotic state with a formal diagnosis of the disorder. According to sociocultural theorists, individuals with DID then feel as though they have a safe and legitimate excuse to misbehave, perhaps even indulge in criminal activities. Some studies have supported the fact that DID is merely a convenient construction and conscious enactment. Lilienfeld, Lynn, Kirsch, et al., 1999. Further, it has been found that individuals who fantasize often score higher on measures of dissociation. McNally, Clancy, Schachter, et al., 2000, Waldo and Merritt, 2000. 5.3 The cognitive perspective. For dissociative disorders, cognitive theorists suggest that they are basically disorders of memory. Dorahy, 2001. As noted previously, patients with dissociative disorders have their procedural and semantic memory intact, i.e. they can carry out skills and remember general knowledge. It is the episodic memory, i.e. memories of personal life events and autobiographical information. Psychology paper number 15, Clinical Psychology. Which is affected. Even the implicit memory of certain past information is partially impaired. 2 theories of cognitive dissociation have been proposed, theory based on state-dependent memory and the source monitoring deficit theory. The theories suggest that patients of dissociative disorders experience retrieval failure. The former maintains that recalling an event is easier for individuals if they are in the same mood state that they were in when the event occurred. Putnam, 1997, Bauer, 1994. This is called state-dependent memory. The theory therefore suggests that dissociative amnesia can be reversed if a specific mood state were to be triggered. For DID, it is known that the alters are indicated by the different moods. Hence, state dependency may cause one personality to have amnesia for the other in its experiences. By the same logic, triggering of a certain mood state may trigger the switch to the corresponding alter. The former is a theory based on our reconstructive memory. According to this theory, patients of dissociative disorders, especially DID, are unable to establish an association of the emotions, context, perceptual features, etc. of a memory and therefore unable to recall it. The alters are not able to arrange the memories of other alters in a way that they can be retrieved. 5.4 The biological perspective. Although somatoform disorders have been thought to be unexplained by known organic causes, many studies have pulled in data to suggest that there may be a genetic and neuropsychological explanation for somatic symptoms. Comprehensive neuropsychological examination, auditory evoked response potentials, and cerebral blood flow studies of patients with somatization disorder demonstrated that these individuals display excessive distractibility, an inability to habituate to repetitive stimuli, and cognitive functioning characterized as concrete, partial, and circumstantial. These findings are associated with bilateral frontal and right hemisphere dysfunction. Floor Henry, Fromach, Tapper, and Schopflocher, 1981, Gordon, Cryuhine, Mears, and Hausen, 1986, Wickramascara, 1989. In sum, somatization disorder patients may have faulty perception and assessment of somatosensory inputs due to attention deficits and cognitive impairments. For conversion disorder, it has been suggested that symptoms result from some form of damage or malfunction of the brain. Ludwig, 1972, Whitlock, 1967. Brain imaging studies indicate that there is hypometabolism, slower processing than normal, of the dominant hemisphere and hypermetabolism, faster processing than normal, of the non-dominant hemisphere, causing impaired communication between the hemispheres. Where pain disorder is concerned, neurotransmitters serotonin and endorphins are said to play a major role. It is a deficiency of these neurotransmitters and the general chemical abnormalities within the patient's body that predispose certain individuals to experience pain and develop pain disorders. Genetic relationships have also been found for somatization disorders. Studies have noted an increased prevalence of 20% of somatization disorder in first-degree relatives of index cases. Cloninger and Goose, 1970, Goose, Cloninger, Martin, and Clayton, 1986, Warner and Goose, 1968. This means that if an individual has a relative with somatization disorder, the individual is 20% more likely than someone who does not to develop somatization disorder. Adoption studies yielded a similar finding. A concordance rate of 29% in monozygotic twins and 10% in dizygotic twins has been reported, indicating a genetic effect. Bowman, Cloninger, von Noring, and Sigvardsson, 1984, Cloninger, Sigvardsson, von Noring, and Bowman, 1984, Sigvardsson, von Noring, Bowman, and Cloninger, 1984. Psychology paper number 15, Clinical Psychology. Where dissociative disorders are concerned, some neuroscientific evidence suggests that dissociative symptoms may be the consequence of undiagnosed epileptic seizure. Civic and Lynn, 1995, Shako and Marie, 1892. Epileptic patients report symptoms such as blackouts, fugues, depersonalization, etc., which are akin to symptoms experienced in dissociative disorders. Further, the limbic system, particularly the hippocampus, has been identified to play a role. The hippocampus is responsible for drawing memories from the various parts of the brain, for instance visual information from the occipital cortex, and so on, and integrating them as a whole so we may retrieve meaningful memories. However, stress can change the structure of the hippocampus and derail its functionality. This includes the shriveling up of cells within the hippocampus as well, altering the release of neurotransmitters concentrated in the hippocampus. The assumption is that if dissociative disorders are a result of chronic stress, the hippocampal structure would be altered such that it cannot gather memories and symptoms of the disorder begin to surface, resulting in amnesia or DIT. Bremner, Crystal, Charney, et al. 1996, Bremner, Crystal, Southwick et al. 1995. In addition to the hippocampus hypothesis, neuroscientific research also suggests that abnormality in serotonin levels may be responsible for dissociative symptoms. For instance, patients suffering from depersonalization disorder report having migraine-esque origins of which are in serotonin functioning. Lower levels of serotonin is implicated in depersonalization. Simeon, Stein, and Hollander, 1995. 6. Treatment. Treatment of somatoform and dissociative disorders is a complex task given the ambiguities of its causal factors and resemblance to neurological diseases. However, some therapeutic techniques have been found to be effective for certain patients. These therapies include pharmacotherapy, i.e. administration of drugs, as well as psychosocial therapies borrowing from various perspectives of cognitive, behavioral, and sociocultural nature. 6.1 Pharmacotherapy. The basis of this therapy is that neurological defects are playing some role in causing somatic symptoms. Therefore, for body dysmorphic disorder, serotonin-specific drugs such as tricyclic antidepressants have been found to reduce symptoms in at least 50% of patients. For pain disorders, analgesic medications have been found to cause problems of substance abuse and dependence in patients. Tricyclic and SSRI antidepressants are the most effective pharmacological agents. However, their long-term effectiveness is yet to be established. Wilson and Gill, 1996. Amphetamine may also be an effective drug if the dosage is monitored carefully. For dissociative disorders, the barbiturate sodium amytal or the benzodiazepine lorazepam can be administered to improve retrieval of memories. The use of SSRIs such as Prozac have been found to be useful for some patients to relieve depersonalization. Simeon, Stein, and Hollander, 1995. 6.2 Psychosocial therapies. The behavioral treatment for somatoform disorders functions on the principle of reinforcements. It employs a two-pronged approach. Since behaviorists endorse the view that somatic symptoms are learned as they serve a means to acquire attention, exemption from responsibilities, and Psychology paper number 15, Clinical Psychology. Sympathy, the therapist's first objective is to withdraw the positive reinforcement for the illness. For instance, for a hypochondriac, the patient experiences anxiety relief through reassurance by various people and medical professionals, which is a negative reinforcement. The therapist does not give any reassurance and instructs the patient's family to do so too. In one of the 5-year follow-up studies, this therapy successfully cured about half of the patients of their symptoms. Warwick and Marks, 1988. The second element of the therapeutic approach is to build the patient's coping skills, a lack of which is presumed to encourage adoption of the sick role. These skills include social skills training, in which the patients are taught how to deal effectively with other people, and assertiveness therapy, which teaches people to say no to requests when appropriate, indulge in emotional expressions, and build their strength in coping with challenging situations. These therapies intend to prepare the patient for being a functional unit in a social context by expressing himself/herself in a satisfactory manner. The cognitive behavioral treatment is another form of therapy which seeks to change the perception and belief system of the patients. The patient is confronted with questions about his or her symptoms which help to alter the person's attitude towards a specific thought. For example, for hypochondriacs and body dysmorphic patients, the therapist asks questions which make the person revise his or her irrational notions of self, I must look perfect in order to be loved, and adopt a more real perception. Systematic desensitization has also been employed to rid patients of their somatic symptoms. In systematic desensitization, the patient is gradually exposed to objects that trigger irrational fears or anxiety, based on a hierarchy or fears, or increasing intensity of fear to objects, and relaxation techniques are used to overcome such anxiety. This is especially effective for patients with body dysmorphic disorder. Relaxation techniques have also proved to be effective for pain disorder patients in managing pain and for reducing anxiety in hypochondriacal and somatization disorder patients. As the name suggests, relaxation is main objective in this therapy. The patient is urged to close his/her eyes, sit in a comfortable position and let the muscles loose while focusing on breathing slowly and naturally. All these conditions stimulate a meditation experience and help the patient relax. In behavioral therapy, relaxation techniques are used to replace anxiety as the patient learns to associate relaxation with the originally anxiety-provoking object. For dissociative disorders, the psychodynamic therapy is the most common and widely used on patients. The therapy progresses across 3 stages. The first stage includes making the patient comfortable and enabling trust so the patient can nurture some control over the dissociative symptoms. The second stage consists of revealing the hidden trauma thought to cause the symptoms and acceptance of the same by the patient. The last stage involves reintegrating the memories so that defense mechanisms are not used to shut them out again. The traditional method of hypnosis is still used to recover the latent memories. In some cases of hypnosis, dissociative disorders may exacerbate and re-traumatize the patient. This is known as aberrations, wherein the patient unnecessarily re-experiences the traumatic event and consequent prolonged emotional crisis. Therapists are cautious to avoid aberrations. Ross, 1997. Sometimes the dissociative disorder is discovered, or even created, in the patient. Destun and Kuiper, 1996, Powell and G., 1999. Behavioral and sociocultural theorists propose reinforcement to treat dissociative symptoms. Spanos, 1996. The trick suggested is not to validate the person's dissociative symptoms. For instance, the close family members shall show no interest in the various alters of the DID patient. Further, the person with the dissociative symptoms should be expected to play a responsible role within the family and community so that there is no positive reinforcement of escaping the responsibility by indulging in dissociative behavior. It has been found removal of reinforcement in such a manner reduces the surfacing of alters. Kohlenberg, 1973. Further, patients must be encouraged to deal with emotions in a socially responsible manner. For instance, Psychology paper number 15, Clinical Psychology. The patient can be taught to express anger through assertiveness training so they do not become latent and trigger dissociative. Symptoms Price and Hess, 1979. Cognitive techniques have also been used by therapists to treat dissociative symptoms Brand, 2001. Therapists aim at awakening the implicit memories of patients so that some crucial past information can be gained even if the patient doesn't consciously do so. Tactical integration therapy, which merges cognitive behavioral and psychodynamic perspectives, has been found to be effective for treating DID-Fine, 1999. The therapy aims at challenging cognitive distortions and irrationally dysfunctional beliefs due to past traumas through techniques such as hypothesis training and retribution training. The patient is then helped to master his/her emotions and manage them effectively. 7. Summary. Somatoform disorders are presence of bodily symptoms without any known physical or organic cause. The diagnostic criterion of the disorder is given by the DSM. The syndromes which have been identified under somatoform disorders are somatization disorder, conversion disorder, hypochondriasis, pain disorder, and body dysmorphic disorder. Dissociative disorders occur in individuals who display a disintegration of consciousness, identity, and/or memory, usually due to emotional trauma and abuse. The DSM-IBTR identifies 4 syndromes as dissociative disorder. These are dissociative identity disorder, dissociative amnesia, dissociative fugue, and depersonalization disorder. The psychodynamic perspective and the behavioral and sociocultural perspective have produced widely accepted explanations for somatoform and dissociative disorders. Dissociative disorders also find explanation of possible causal factors by the cognitive theorists. The treatment options for somatoform disorders are not very specific. Treatment includes the drug therapy approach and the psychosocial therapeutic approach. For dissociative disorders, the psychodynamic approach to therapy has proved most effective. Other therapies include behavioral and cognitive approaches to treat the dissociative symptoms. Induction. 2.1 Stress and trauma. Stress is basically a result of threatening and disturbing situations which cause the human being's body to suffer from disequilibrium or homeostasis. It is important for the person to gain back his homeostasis in order to rectify and rebuild his or her emotional and cognitive organizations. In our daily lives, we may suffer from 2 types of stress, namely stress negative and eustress positive. Eustress is also called positive stress because it is experienced at times such as when an individual is preparing for his examination or a presentation. This eustress provides motivation to the individual. The stress caused in eustress is taken in a non-harmful manner because it does not interfere with the person's cognitive functioning. Another important term one needs to remember is the stressors. Stressors are objects, situations, or stimuli that cause the stress. Stressors have no particular or specific demarcation. They may be of the slightest of danger to the person and sometimes they may be at the highest pressuring level. Trauma, on the other hand, is defined as an event that is caused due to human or nature, and leads to challenges being faced by the individual associated to food, shelter, and safety. The 1987 edition of DSM-3R defines traumas as the events that are usually outside the range of the normal life events. The definitions of trauma have been revised several times since then. There are 3 types of stress disorders. Post-traumatic stress disorder, PTSD. Dissociative and conversion disorder, acute stress disorder. Psychology paper number 15, Clinical Psychology. 3. Post-traumatic stress disorder. The DSM-IV presented with a criteria and a number of symptoms which need to be met in order to be diagnosed with PTSD. The DSM stated that a person suffering from PTSD must have at least 3 numbing, 2 symptoms of hyperarousal and 1 intrusion. Out of the following, the person must show or report at least 3 numbing or symptoms that show avoiding behaviors. Ignoring any type of feelings or conversation about the traumatic event. Making a hard effort to avoid going to places or seeing or meeting people who have been associated to the event in some way. Not being able to remember any aspect of the trauma. Lack of interest to participate in any activity. Showing numbness and being emotionless. Restricted range of affect, no futuristic plans or views. Out of the following, any 2 of the hyperarousal symptoms must be present or reported by the person. Lack of sleep. Anger bursts very often. Lack of concentration. Hypervigilance. Extreme and exaggerated responses. The patient must report at least 1 of the following intrusion symptoms. Repeatedly occurring and intrusive flashbacks of the trauma. Nightmares. Illusions or hallucinations. Extreme distress etiology. Biological factors. Hippocampus and the amygdala are the 2 parts of the brain which are responsible for emotions and memory of an individual. Thus, when the traumatic event takes place, these 2 brain systems get activated and are held responsible for the memory and the related emotions with the trauma. There are 2 types of hormones which are also responsible in forming traumatic memories. Psychology paper number 15, Clinical Psychology. These hormones are cortisol and norepinephrine. These 2 hormones rise in level when there is a memory recall of the traumatic event, which leads to the fear arousal in the individual. Classical conditioning model. In this case, the individual is stuck in a cycle, where he keeps experiencing negative emotions which are associated with the traumatic event. The individual is unable to avoid the emotions which arise due to the memory of the trauma. Thus, it forms a vicious cycle which is difficult to stop. Events or trauma that could lead to PTSD. Death of a loved one. Wartime. Sexual abuse. Childhood trauma or neglect. Natural disasters. Rape, terrorist attacks. Treatment of PTSD. Debriefing. This form is not exactly a treatment but a way of preventing PTSD from happening. In debriefing, the person who has been in the trauma or has witnessed the trauma is talked to. It involves only 1 interview where the helper or the professional tries to talk to the victim and tries to encourage him to speak about the event. This helps the person to let out his emotions. Debriefing is believed to have positive effects along with negative ones by pushing the victim closer to PTSD. It helps to avoid secondary traumatization, that is, helps in avoiding the person from any further imagination about the trauma. Exposure techniques. This type of intervention involves the exposure of the most traumatic part of the traumatic event that took place. The person suffering from the trauma talks about the event to such an extent until a point where he stops feeling any type of distress and trauma. This technique is very commonly used to overcome traumatic events. Eye movement desensitization and reprocessing (EMDR). This technique was developed and discovered by Shapiro, 1995. This technique is one of the most popular and effective techniques. Family therapy. In this type of therapy, the patient gains love and support from his loved ones or the family. This type of therapy provides the patient with support and a reason to live happily. Pharmacological intervention. There are many drugs involving some antidepressants such as MAOIs, SSRIs and tricyclics which have been effectively used for the treatment of PTSD. Psychology paper number 15, Clinical Psychology. 4. Dissociative disorders. 4.1 Dissociative amnesia. According to the DSM-IV, dissociative amnesia is characterized as a type of dissociative disorder. Dissociative amnesia is characterized by the forgetting of important information about self. Forgetting like this is associated with the explicit memory such as personal information or information about the past and implicit memory such as general knowledge. Amnesia can be of three types: generalized amnesia, localized amnesia, selective amnesia and systematized amnesia. Generalized amnesia is one which involves forgetting of personal information. Localized amnesia is one where the person forgets about for a certain period of time. Selective amnesia involves forgetting some parts of an event or act. And finally, systematized amnesia is one which includes forgetting a category of information such as forgetting all memories of one's family. The onset of dissociative amnesia starts when there is uncontrollable stress and trauma such as times of war, loss of a loved one, death, violence, natural disaster, etc. 4.2 Dissociative fugue. Another type is the dissociative fugue. This type of dissociative disorder is defined by DSM-IV as a sudden wandering away from home or place of work. In this disorder, the person is confused with his personality or self. It is believed by several researchers that it is more likely that the patient is confused with his own present identity rather than acquiring a new identity altogether. There is great evidence about the fact that dissociative fugue and dissociative amnesia is a result of trauma and too much stress. Psychiatrists also talk about the soldiers in war who suffer from immense trauma and stress and thus suffer from these stress disorders. 4.3 Depersonalization. According to DSM-IV, depersonalization is defined as repeatedly occurring and persistent feeling of being detached from one's own self, identity, physical body and mental process too. There are chances that the therapist may diagnose these symptoms as psychotic symptoms. But these symptoms differ from delusions etc. in one way, that they are present without the impairment of the reality. The person suffering may feel detached from his own body or may feel alienated, unreal and dead, but he is not detached from the reality. The patient suffering from depersonalization feels like he is like a robot or a mechanical machine which is detached from the environment. Psychology paper number 15, Clinical Psychology. There are 4 major characteristics of depersonalization disorder. A sense of alteration in self's body such as feeling like one is not in his own body. A precipitating factor such as substance abuse or an injury. A feeling like one is in a dream and everything seems unreal. Sensory alterations. Like most dissociative disorders, the causes for depersonalization disorder is the trauma, stress, child abuse, domestic violence or any other type of stressful event in childhood or at present. 4.4 Dissociative identity disorder. Dissociative identity disorder has a major characteristic which helps in diagnosing this disorder. Patients suffering from DID behave in such a manner as if they possess 2 personalities or identities. These personalities or identities are also called alters. In the past, patients were diagnosed with few personalities. These alters can range from 15 to 100. DSM-IV has given a criterion for DID as follows. The person must possess more than 2 alters or personalities. Each personality state should have its own pattern of perceiving the world around, thinking and the way of behaving. At least 2 of these 2 personality states must be dominant at different points of time and take over the control of the person's behavior. The person is unable to recall the actions or the things said at the time the person possesses one alter. The disturbances or changes in the personality are not due to any physical problems, substance abuse or any type of medical condition. The basic task of the alter personalities is mainly to protect the host personality from all the dreadful and threatful memories from coming up or being remembered. These alters arise in order to keep the host personalities safe and as a result of all the childhood abuses the host personality has tolerated. The number of alters depend upon the amount of time it has been or the severity of this disorder. Each alter plays their own role and sometimes one alter may know about all the other alters as well as the host. There may be great variation in the alters. Some may speak a different language while some could be or different gender, some may also be old whereas some may be just a child. The main cause which may lead to the switch from one alter to another may be due to a stressful situation or something that might have upset the person. Psychology paper number 15, Clinical Psychology. When the person undergoes a change in alter, he or she may not remember anything about what happened moments ago or where he or she is. The person feels like he is losing a lot of time or he might feel that he has no clue how he ended up in a particular situation or with a particular person. Etiology. Childhood trauma. It is believed that children who have suffered from child abuse or trauma are at high risk of acquiring this disorder. Studies show that most cases report childhood trauma. The psychologists believe that during the childhood the child is unable to protect and defend himself from all the abuse, thus he develops an alternative self or personality which comes out when the child feels that he is going to face danger or threat or abuse. Socio-cognitive model. This model, on the other hand, says completely the opposite. It says that the patient's childhood trauma has nothing to do with this disorder, rather it is the patient's own way of dealing with stress. When the patient is under immense stress and pressure, he tends to behave in such a manner and develops an alter. More the stress, more the alters. Treatment. 2 different psychologists, Spanos 1994 and Gleaves 1996 gave their own ideas about the treatment of DID. Spano said that DID can be treated by making the patient or the host or the original personality aware of all the other personalities and make him believe that they are real. Gleaves, on the other hand, believed completely the opposite and proposed a completely opposite method of treatment. He believed that instead of making the person realize that these alter personalities are real, the psychologist must make the patient aware that these personalities are just self-made and are not real. The psychologist must make the patient realize that these are virtual people or thoughts, not real people. Freud believed that hypnosis could help in treating DID. Hypnosis helped the psychologist to talk to each and every alter to recall all the bad memories and then start detraumatizing the patient. Another goal of psychologists or therapists in order to treat the patients with DID was to help them get all the personalities into one personality. This process is known as fusion. A number of techniques were used to help the patient to go through the fusion process. These techniques include play, guided imagery, life skills teaching, projective techniques. Psychology paper number 15, Clinical Psychology. And group therapy to help bring awareness and understanding of other selves, and through this eventually achieve cohesion between all alters. Major effects of dissociative disorders are ending up in a place which is unknown and unfamiliar, distortions in the body, gaps in memory, unrealistic feeling of self, voices from inside, feeling of detachment, changes in perception, forgetting, lack of social interaction, confused feeling of identity, finding items in your possession that you don't remember buying or receiving, writing in different handwriting, having knowledge of a subject you don't recall studying. 5. Acute stress disorder. The major characteristics of acute stress disorder are not very different from those of the PTSD. The development of extreme anxiety, symptoms of dissociative disorders, and several others that occur within the time span of 1 month of the trauma or the stress or loss of a loved one. Other symptoms are withdrawal from enjoyable activities, social gatherings, lack of self-care, low emotional responsiveness, and a feeling of guilt and blaming oneself for everything. Someone who suffers from an acute stress disorder is one who experiences symptoms including a feeling of detachment from one's own body, feeling like one is in a dreamlike state, lack of concentration, and also an inability to recall parts or specific aspects of the traumatic event, dissociative amnesia. Another important thing about acute stress disorder is that it involves at least one symptom from each cluster of symptoms for PTSD. These symptoms have been mentioned in the section about PTSD above. The DSM-V listed 5 main diagnostic criteria. The first criterion includes any serious accident or injury, sexual abuse of any kind, or death. Psychology paper number 15, Clinical Psychology. First-hand experience of the trauma. Eyewitness of the traumatic event. Hearing about the death of a close one or a friend, experiencing various details or information about the traumatic event. The second criterion of DSM-V is that the person must report at least 9 to 14 symptoms out of the following 4 categories mentioned ahead, which may start or worsen after the trauma. Intrusion. Repeatedly occurring thoughts and memories of the traumatic incident. Nightmares. Flashbacks of the trauma occurring or repeating itself, prolonged psychological and physiological reactions. Negative mood. Inability to experience happiness or satisfaction. Dissociative symptoms including losing time, forgetting important parts of the traumatic event, dissociative amnesia, and feeling unreal. Avoidance symptoms. Making efforts to avoid distressing thoughts and memories about the trauma. Making efforts in order to avoid the places, people, objects, situations, etc. that remind or are associated to the traumatic event. Arousal symptoms. Difficulty in falling asleep or staying asleep. Irritability and mood swings. Lack of concentration. Exaggerated response hypervigilance. The third criterion for acute stress disorder is that the symptoms mentioned above or the disturbances seen should be at least 3 days to 1 month after the traumatic event has taken place. The fourth criterion is that these symptoms or disturbances must cause clinically significant effects in the person's social, personal, and occupational functioning. The last and the fifth criterion is that the effects or changes must not be attributed or due to any sort of substance abuse or physiological cause. The acute stress disorder may also continue and may result in PTSD. But there are chances that within 1 month the patient is treated and the disorder may not result. Psychology paper number 15, Clinical Psychology. Lead to PTSD. About 50% of patients develop PTSD after a month of being diagnosed with acute stress disorder. Treatment. Pharmacological intervention. Just like PTSD, SSRIs, tricyclics and benzodiazepines are extremely effective and helpful for acute stress disorder. Cognitive and behavioral therapies. Exposure to the information related to the trauma. Eye movement desensitization and remission, EMDR. Psychodynamic psychotherapy. Focus on the development and relationships of the person. Present-centered and trauma-focused group therapies. 5. Summary. Stress is basically a result of threatening and disturbing situations which cause the human being's body to suffer from disequilibrium or homeostasis. 2 types: stress negative and eustress positive. Trauma, on the other hand, is defined as an event that is caused due to human or nature, and leads to challenges being faced by the individual associated to food, shelter, and safety. Post-traumatic stress disorder is the major stress disorder. DSM-IV presents the criteria for PTSD. Several treatment techniques have also been used. Dissociative disorders, dissociative amnesia, dissociative fugue, depersonalization, and dissociative identity disorder. Acute stress disorder is another stress disorder which has been introduced, and the DSM-V also presents its criteria. Its treatment is more or less the same as that of PTSD.